we start, sir? It's already 2:37. Shall we go ahead, sir?
Yes, yes. Start.
Okay, I think that the participants have joined. Good afternoon, everyone. So we have seen in this COVID-19, many of us got into psychological ups and downs, and most of the patients started with the psychiatric disorders also. In my experience, I have seen compared to all psychiatric disorders, the patients are suffering more with the mood disorders in this COVID-19. So thereby we came up with this today's webinar on mood disorders. So as a homeopath, one should not miss this diagnosis based upon which we will be clear about our approach towards these cases. So myself, Dr. Jayashree Janagam, I'm an assistant professor in the Department of Psychiatry, NHRIMH. I welcome you all once again. Now, to begin with today's webinar, I request my colleague, Dr. Gyana Prakash, so MD Psychiatry, assistant professor in the Department of the Psychiatry, to deliver the welcome speech. Dr. Gyana Prakash, over to you. I request all the participants to unmute, to mute themselves. Yeah, Dr. Gyana Prakash, are you here?
Yes, ma'am. Yes, ma'am.
Yeah. Please go ahead, doctor.
Good afternoon, everyone. I think I am audible.
Yeah, you're audible, doctor. Please go ahead.
Yeah. Thank you, Dr. Jayashree. So, as a part of our continuous short CME program from our institute, NHRIMH, that we initiated from this Jan 2020. Every month we have a short learning process through webinars and also the direct conferences. Due to COVID-19, I think we are able to communicate through this webinar. So as Dr. Jayashree told, we are passing through a lot of mood disorders due to this COVID outbreak. So as a part of this, and we are getting a lot of cases related to this COVID-19 pandemic, that is psychological stress, behavioral problems, and a lot of suicidal cases. Even we are hearing a lot of cases, even the famous Rajkot's death also. So all this rise, that is psychological stress rise, that is due to this COVID-19. So basically, as a homeopath and being a mental health professionals, we should know basic or clear idea regarding what is mood disorder and how to diagnose it, and when to refer to a psychiatrist, and through which extent, so to what kind of extent we can give counseling techniques, and what are the limitations we have actually, and what are the advantages we have. So on behalf of our learning process, this continuous medical education, so I am welcoming all the participants. I think nearly we are having 58 participants. So to make our mood stabilize, we light our mood in a bright condition. So I welcome all the participants first, and also I welcome on behalf of Officer in Charge, Dr. P.S.M. sir, and all the kids, and also my friends and colleagues. Thank you very much for calling. So I hand out to Dr. Jason. Thank you.
Thank you very much, Dr. Gyana Prakash. Now, to begin with the session, I would like to welcome our officer in charge, Dr. Muralidharan sir, to give some few words to begin with this today's webinar. I request Muralidharan sir. Sir, please, over to you.
Good afternoon, one and all. Am I audible?
Yes, okay, sir. You're audible, sir. Please go ahead.
Yeah. Okay. So this is part of our short CME program, and which we have we have decided pre-COVID era. Now it has been a routine thing in online platform. So we are utilizing those platforms right now for disseminating the whatever knowledge available with us, whatever the knowledge available in the world. So this is an opportunity for all the people, those who are interested in psychiatry, and especially in homeopathy, because the National Homeopathy Research Institute.
So your voice is not audible, sir. Excuse me, sir. So your voice is not audible.
People, I think, are our prospective research officers also join here. Those who are got selected in research officer post in CCRH. So welcome you all to this wonderful webinar, and thanks to all the faculties, all the psychiatry faculty and all the medicine faculty to organize such a nice program. So thanks to one and all, and welcoming all of you to this wonderful program. Thank you so much.
Thank you very much, sir. Now let me introduce Dr. Karunakara Moorthi. Dr. Karunakara Moorthi, he is a research officer, scientist to associate professor in the Department of the Psychiatry in our institute. So he has completed his MD Homeopathy and started his career as an assistant professor since 2008 to 2012 at Vinayaka Mission, Homeopathic Medical College, Salem, Tamil Nadu. Currently, he is working as a research officer since 2012 and also an associate professor at NHRIMH in the Department of the Psychiatry under CCRH. He is an investigator in 5 research projects from CCRH. His recent projects includes management of adjustment disorders with homeopathic interventions, a prospective single-arm open-label exploratory intervention study. And the other one is a survey to evaluate the prevalence of psychiatric symptoms among OPD patients using self-reporting questionnaire. He also published several research articles into peer-reviewed journals. Recent article was on prevalence of stress and anxiety among the bank employees in India during lockdown due to the COVID-19. So I welcome Dr. Karunakara Moorthi. Please go ahead and you can start with your topic today. Over to you, Dr. Moorthi.
Yeah, thank you, Dr. Jayasri, for your kind words. Is it audible? My voice is audible?
Yeah, you're audible, doctor. Please go ahead.
Yeah, right. Just permit me to share the slide.
Yeah, I have stopped sharing from my side. Now you can go ahead.
Okay. Yeah, very good afternoon to all. Dr. Jayasri, my slide is unable to see.
Visible.
Yeah, thank you. And very good afternoon to all. And I hope that everyone had your lunch, isn't it? Because after lunch, taken your lunch, please don't go to the sleepy mood. Stay active. Then only I can convey the message about the mood disorder. And I'm not going to say anything new. What are the things which is in the theoretical book, and as well as some of section under the neuroscience, I will explain about the replicated study, research study about the mood disorder. I want to emphasize over in the mood disorder. And just apart from theoretically, I'm going to brush up with the topics. Okay, let us go to the slide. And so these are all the topics I'm going to discuss with you today, like history, introduction, neuroscience, and disorder. There is important sections in the mood disorder because many questions has risen here. How does the mood disorder happen? What is the reason behind that? What are the causes? What is the reason for their behavior and the hormonal changes? And as well as in theoretically said unipolar, bipolar disorder, clinical features, And here, most of the clinical feature correlated with the mental status examination, how to diagnose the patient. That is very important over here. I'm going to emphasize that also. And risk factor, comorbidity, differential diagnosis as it is. And regarding assessment of scale, what are the scale we are using for the diagnostic purpose? And homeopathic management, I'm doing a little bit rubric also, and also adding in how, what is the way and what are the way to prescribe for the, especially for the mood disorder patients. And finally, bibliography. And before moving to the topics, I would like to explain about the evolution about the mood disorder. And about 400 BC, Hippocrates described about the melancholia. Just a minute. Melancholia, and around 30 AD, the Roman physicist, he is also quoted the same in his study. And 1854, Jules Falret described about the alternating moods and depression and mania. In his study, Folia Circular, Mendel was the first person to define about hypomania. In 1882,
But your voice is not audible, Dr. Moorthi.
mania and depression as stages of the Emil Kraepelin described manic depressive psychosis using the most of the criteria for bipolar 1 disorder, and previously manic depressive bipolar mood disorder as well as dementia precox. It is an old term of schizophrenia. Having similar kind of psychotic symptoms. So he wants to distinguish or differentiate from the dementia precox. He bring out certain criteria under the bipolar 1 disorder to differentiate from the schizophrenia. He understood that it's not a short term; it is a long term course, as well as it's a having tendency to return to disorders. And full of feast and learn identify heterogeneous natures. In every patient like manic patient, a manic depressive and as well as everything under the bipolar disorder, it comes under the same illness, but the stages is different. That they emphasized, and they coined and unipolar. And we'll go to the introduction. In order to understand the mood disorder, first we should understand what is emotion, what is affect, and what is mood. Because emotion is there, and emotion can be perceived in two forms, like mood and affect. What is mood? Mood is a pervasive and sustained emotion. Like pervasive, how they express in total, whatever the thought, action, what is the behavior, totally pervasive. The total or whatever they are doing regarding its complete mood, and sustained. It will be present for a long period. So pervasive and sustained, these are the two words stand for the mood and how the patient expresses. Like empty, melancholic, angry, heightened, gleeful, and dramatic. So how we can identify the mood? Through the clinical evidence. Like first, activity level, either increased psychomotor activities or reduced psychomotor activities. And cognitive abilities like thinking, understanding, memory, everything. And speech, how they are speaking, what is the tone of the patient, everything. And vegetative functions, like what is the appetite, libido, thirst, everything comes under the vegetative functions. So apart from that, there is the interpersonal relationship, social and occupational function is totally impaired. To the affect. Affect immediate expressed and observed emotion. And how normally it will be expressed, how we can identify the patient by the facial expression, pitch of voice, gestures, and movement. And simply I will explain that it's a theoretical part. Apart from that, we can discuss that how I can understand the mood of the patient and affect of the patient. See, I will give some example. If you are taking the climate of the Kerala, you consider with the mood of the patient and weather. What is normally we can say that climate of Kerala is a cold climate. So normally, what is the patient mood? How normally what is my mood? Whether I am irritable or I am very easy taker, or I am very easily offended personality, or very melancholic nature. This is my total nature, pervasive natures. And weather, what is the at present weather now, like rainy season? So how the patient expressed their mood through the emotion. For example, I'm giving that I'm the irritable mood. If any person come and ask that, like any provoking, slightly provoking, I will express through the either by spitting or by beating. And mostly in our clinical practice, day-to-day clinical practice, we used to see that not from the psychiatric, in even pediatrics. For example, if the patient's mother saying that, sir, my son is always lying, or is a liar, or stealing the things, or his tendency to hurt others. When we are enquiring the patient how he is behaving, like we are asking whether he is stooping his head, or stamping his feet, or rolling in the floor, or knocking the wall with his hands. These are the type of emotion. Based on this emotion, we can prescribe. Not only based on a single symptom, we can take it as a whole, but also these are the characteristic features can find out the prescription of symptoms. And I hope that you understand between the affect and the mood, because this is the main theme of the mood disorder. If we can understand how the mood of the patient, how the emotions of the patient, we can prescribe easily, as well as we can diagnose the patient also easily. This is a very, very important. And under the emotion, it will come to the quantity of emotion, quality of emotions, and range of emotion. Or wherever we are seeing, the person is never open-ended. Like simply, whatever, if you're asking the question is expressing very simple or very monosyllables. So now reduction of that is called reduction of expression. If the reduction of expression is going very severe, it's called a blunt affect. If there is a no emotion, it comes into the flat affect. And blunt affect and flat affect mainly we can see in the schizophrenic patient, as well as the schizotypal personality disorder. And congruency, finally, congruency, what is the thought of the patient, what is the actions of the patients. My thought and action should be the same. If there is an inappropriate present between the thought and action, called as in. For example, I am saying my father is dead. So how should I, my emotion should like weeping or crying or feel brooding. And instead of that, if I am laughing or jumping, it is inappropriate. So that thought and action should be the same. And it's regarding epidemiology. And bipolar disorder most commonly we can see in the men and women. Mostly mania occurs in men, and depressive episode we can see in the women. Come to the genetic mood disorder. Since so, and hydrolase gene, it's very correlate with the in the impulsivity associated mood disorder. And main chromosome like long arm and short arm, mainly here short arm 18, 21q and 22q have evidence of linkage to bipolar disorder. And neuroscience in mood disorder. What is there is a dysfunction, brain dysfunction, or there is a changes in the metabolism occurs in the bipolar affective disorder. Like if you are taking left hemisphere, dorsofrontomedial cortex volume is reduced, paracingulate cortex volume is reduced, and left hemisphere of amygdala volume is reduced. And regarding metabolism, right hemisphere of pre-genual anterior cingulate cortex, subgenual anterior cingulate cortex. I am not simply saying that decreased volume due to bipolar affective disorder, increased metabolism due to bipolar disorder. I will explain how the volume of the brain is reduced in the pathological path. And you know that most of the limbic systems are very associated with the mood disorder. For example, any changes like cingulate gyrus, amygdala, hippocampus, fornix, and septal nuclei. These are the limbic system. So any loss of healthy functions or any inflexibility or more flexibility, so it leads to emotional disturbance and leads to mood disorders happen. And just look into the pictures, colored pictures. These are the areas are involved in the mood disorder. Come to the neurochemistry. And I said already the biomarkers, even though we are not ascertain, it's having their unique role. Each and every, like serotonin, norepinephrine, dopamine. These are the monoamine neurotransmitter, including histamine. And the monoamine neurotransmitter, serotonin, norepinephrine, and dopamine will reduce in the depression, and serotonin seen increase in the manic patient. Come to the circadian rhythm. And regarding circadian, you know that circadian rhythms are 24-hour cycles, and it's having main role of sleep and cortical secretion. So if there is any disturbance in the circadian rhythm, it leads to mood disorder. If the patient having mood disorder, it leads to disturbance of the circadian rhythm, because it's a bidirectional relationship. Because melatonin, like hypothalamus suprachiasmatic nucleus, which is located in the hypothalamus, it's having the primary role of controlling the circadian rhythm. So if there is any distance between the sleep, cortical secretion, or melatonin function, circadian rhythm totally disturbed. If the circadian mood disorder will be. And come to the neuroendocrinological part. Bleuler was among the first to investigate associated and behavior. And previously I said that circadian rhythm and mood disorder is a bidirectional relationship. Just like endocrine symptoms also is a bidirectional. So if any dysfunctions occurs, leads to hormonal changes. If the hormonal changes will occur, leads to mood disorder. Like any disorder in the mood disorder will come, and leads to behavioral changes. What is in between? There is a neural circuit. The sensitive part of the neurons is regulating the hormone. If there is any difficult to adapt or cope up with demand by the neural circuit, it leads to endocrinal dysfunction and finally getting the mood disorder. It's also bidirectional relationship. And bipolar affective disorder and depression. Because why I'm segregating means in most of the depressive patients, increased salivary cortisol and increased hypothalamo-pituitary adrenal axis activation and increased TSH. So coming to the total bipolar disorder, increased systemic cortisol metabolism will be present in the bipolar disorder. So totally cortisol level is hypercortisolism, is the main reason for the one of the reason for the mood disorder. And simply I will explain. If the patient is getting severe stress, not as well as the negative stress, so automatically their hypothalamo-pituitary adrenal activities will be increased and followed by increased cortisol level. And in case of severe stress, 10% of patient can develop suicidal ideation, even psychosis symptom. But another point, even though it is very severe, it is can reversible. That's why sometimes it's called as a reversible mood syndrome. And in conventional treatment, like patient getting thyroid level increase and anti-thyroid antibody level is increased. So their conventional treatment, they used to say that unless these hormones are brought back to the normal, symptoms will be remain. But in our aspect, we are taking the patient as a whole and treating the patient as a whole. So when we are getting the conclusion, the patient's symptoms also reduce as well as their hormone level also come back to the normal. That is the differentiation. And come to the hypothalamo-pituitary adrenal axis. And you know that glucocorticoids are secreted from the adrenal cortex. So its functions, it regulates the neuronal survival, neurogenesis, and anatomical structures, acquisition of new memories. And if there is any dysfunction,
sorry to interrupt.
Yeah,
Can you show the previous slide 1 minute?
Yeah, what?
Please show the previous slide. I didn't read the last slide.
Okay.
Yeah,
It's okay.
Yeah, thanks.
Shall I go to next slide?
Yeah, please go ahead.
Yeah, thank you. And hypothalamo-pituitary adrenal dysfunction. You know, I already said that hypercortisolism. Hypercortisolism is one of the main reasons for the mood disorder. And 50% of those Cushing syndrome are the person who taking oral corticosteroid treatment. If they are taking the medicine, what will happen? Automatically, they develop symptoms like anergia, anhedonia, anxiety disorder, depression, and panic disorder. So, most of we should in our homeopathic part, whenever the patient come to our clinic, when we are treating the patient, it's not get recovery. What are the points we should keep in our mind? You know, we are all very most of the prescribers are very nice prescriber, and some obstacles will be present. Where is the obstacles? What is the reason behind that? Through the help of theoretical part, we can remove that. For example, I am saying that if the patient is taking the hypercortisolism orally, what will happen? Automatically, the mood symptoms will be produced. How the mood symptoms will be produced? I am saying, say, a simple example. If you are taking the oral corticosteroids, what is the function? It automatically increase the energy, taking the glucose energy. So if there is an increase in the taking the glucose energy, automatically to convert it, it need protein. When it's need protein, it increase intake of protein. And finally, what will happen? The protein is a very essential part of the all part, even neutrophil, WBC preparation, and even nervous. Whether the patient frequently get infection or the patient get in the neuronal damage. When the neuronal damage will occur, automatically the patient will get the mood disorder. That is the correlation between the mood disorder and cortisol. And whenever the patient will come, we no need to treat the patient, simply withdraw the medicine. When you are withdraw the medicine, automatically the patient will get recovery. It comes under the reversible mood syndromes. And hypothalamo-pituitary adrenal axis, and next it's come to the TSH and thyroid axis T3, T4. You know that, and you know the thyroid hormone. And I would like to emphasize only 2 points. What is the functions which is related to mood disorder in psychiatry, like neuronal growth and synaptogenesis. And serotonin having the inhibitory role in thyroid releasing hormone, and dopamine has the stimulatory action to the TRH release. So, and whenever I'm saying hypothalamo-pituitary axis, hypothalamo-pituitary thyroidal axis having the relation, where is the lesion? Why it's occur? What is the reason behind it? That is very important. So some research studies says that the patient either having hypo or hyperthyroidism, whatever it may be, there is a neurotransmitter receptor density of noradrenergic and GABA changes perform in the particular brain region. That is the main reason for the disorders. And What are the symptoms? You know that fatigue, memory impairment, irritability, decreased libido, like symptom as set in the theory. And again, I hypothalamic pituitary adrenal axis linked with hypothalamic pituitary thyroid axis, because it's both having strong positive correlations. Hypothalamic pituitary adrenal axis secretion of glucocorticoids, so it having the role inhibiting the thyrotropin secretion. If there is inhibiting the thyrotropin secretion, automatically T3/4 level change. And what I said, that neurotransmitter, neuron receptors density changes, so mood disorder. That is the linkage into the hyper. And there is no much relationship between the male hormones and mood disorder. I will go to the female. You know that most of the time, if the I will, before going to explain about this, I will give a small example. Then only we can understand how it's affect us. If the person who is staying in the north side, if they are coming to the south, or if the person who is living in the south, they are going to the north. Most of them, if for example 10% could not able to adapt the situation. That is the first thing. Somebody, for the survival of fitness, 4 or 5% can able to adapt the situation, and 1 or 2% could not able to adapt the situation. What will happen? The stress is prolonged, followed by long stress. Automatically they'll go to the negative stress. Negative stress leads to getting the mood symptoms. So even not only external environment, the internal biological clock or biological changes, like for puberty, sudden appearance of higher level of estrogen at puberty. See, just notice the word, even the puberty or menopause, sudden changes. It's not going to occur all the persons, only the person who is having the very sensitive. Like for example, I'm saying even menopause. If you're taking menopause, it's a 3 types of menopause, like sudden appear of menopause, and phase by phase manner menopause, and gradual menopause. And they're saying that research study is saying that if the person who is getting the sudden menopause, there is the mood depression or mood disorder will happen. What is the role? What is the reason behind that? If you are taking puberty, sudden appearance of higher of estrogen in the puberty leads to sensitivity of the nervous system, neurotransmitter system. So the sensitivity of neurotransmitter system may lead to increased vulnerability of mood disorder. So come to the menopause. I told that 3 phases: sudden phase, phase by phase manner, and gradual. So for the gradual and phase by phase manner, there is not much proof. But if the patient who is getting sudden menopause, during the menopause, a relative gonadal deficiency will occur. The sudden gonadal deficiency, ovary resisting the to follicular stimulating hormone, because if there is no ova, there is not necessary of follicular stimulating hormone. So automatically what will happen? To reduction of estradiol. So sudden deficiency of the leads to neurotransmitter sensitivity or changes, and leads to it happen vulnerability to mood disorder. I'm not simply saying, I will explain for coming slide about the neuroplasticity. Then you understand that why the neurons getting very sensitive, and what is the changes will occur in the brain system. And regarding reproductive age group, major depressive disorder, premenstrual dysphoric disorder, and postpartum depression, it's common. Then growth hormone, and already I said that these are the articles I collected from the replicated research studies. So what they are saying that if there is most of the study either growth or increased growth hormone and reduced growth hormone, both are having relation into the mood disorder. But long-term study, like if you're taking, there is the long-term study in 10 years, they are taken the depressive patients, long-term study, while going to the sleep, it exhibits the lower level of growth hormone in the 100 minutes before sleep. So deficiency of growth hormone present in the depressive patient. Second evidence, they are compared to the healthy and depressive. If they went into the depressive, the decreased growth hormone responds to the growth hormone releasing hormone. So the response of growth hormone very less in compared to the healthy child. And second thing is a growth hormone very less production 100 minutes before the sleep. It's a long term. So I believe that both its pulse, because since it's a pulsatile manner, when it's not secreting always, mainly it's during the period of exercise, sleep and stress. During the time only it will be pulsatile manner. So both the hypersecretion and hyposecretion leads to mood disorder. Prolactin, most of hyperprolactinemia leads to psychiatric symptoms like depression, anxiety, irritability will occur. I am giving an example, clinical example. Clinically, whenever we are treating the patient is under allopathic as well as with homeopathic medication. If the patient is coming to us, they are saying that they are for the diagnosed as a case of schizophrenia. Automatically, they used to take the antipsychotic drugs. If they are taking the antipsychotic drugs, the male patient used to complain that their enlarged breast size, enlarged like gynecomastia and galactorrhea after taken antipsychotic. Why? What is the reason? So, when you are giving the antipsychotic for the schizophrenia patient, automatically the dopamine level will be reduced. The dopamine help to inhibit the actions of prolactin. So when the dopamine level reduce, it could not able to control the prolactin. So automatically the prolactin level will be increased. So leads to increased breast size and increased formation of milk. Apart from that, erectile dysfunction and visual disturbances will occur. So if you are automatically stopping the medicine, so galactorrhea will be reversed back, and I don't know about gynecomastia. And come to the melatonin, and everybody knows that melatonin is the hormone of darkness. So melatonin mainly seen in increase in mania and decrease in depression. And previous, while I am taking the circadian rhythm, I mentioned that suprachiasmatic nucleus, which is the suprachiasmatic nucleus, any changes will be present or any dysfunction leads to disturbances of the pineal gland. So there is a melatonin secretion. So the melatonergic system will be disturbed. So automatically when the melatonin system will be disturbed, because I said that suprachiasmatic nucleus is the primary control of the circadian rhythm. So automatically the circadian rhythm will be changes, and automatically the circadian rhythm changes, mood disorder will be happen. Dr. Jayashree. Hello.
Yeah, tell me, doctor.
My voice is audible. I'm
audible,
going very fast.
Yeah, audible.
Can you?
Go ahead. Anything is there, I'll be reminding you. Please go ahead.
Able. Okay. Thank you. And come to the parathyroid hormone. Either increased parathyroid hormone or hyper or hypo, both it having role in the mood disorder. And most of the patient who is come to the clinic like total thyroidectomy, those used to get the delirium, difficult to concentrate, emotional lability and cognitive impairment. So it's having the role of both increase or very deficiency, it having the role with the mood disorder. And emphasis very few points. Hyper glucocorticosteroid secretion is having the main role. And whenever the patient is coming to the antipsychotic, we should concentrate more. These are the obstacles for the recovery. And main thing I said that due to neuronal changes, mood disorder will occur. Due to neuronal changes, neuronal sensitivity, mood disorder occur. Why? What is the reason behind that? I'm explaining with this slide. So what is neuroplasticity? Neuroplasticity is the ability of the nervous system for what? To respond as well as adopt its functions for the different demand. I given previous slide. I have given some example. If the person who is coming to the other side, outer side, they could not able to adopt this situation, so they used to get the stress. The same thing, sudden changes. If there is any sudden changes, there is leads to mood disorder will occur. So what is the functions of nervous system, like neurotransmitter system? Synaptic remodeling, axonal sprouting, neurit extension, synaptogenesis, and birth of new neurons. This is the functions. This is the regulating the work. So if there is any sudden changes, it could not able to respond properly, or it could not able to adapt with the functions, or it could not able to cope up the demand. So surely there is a sensitivity of nervous system. If there is a sensitivity of nervous system, the following regulation will be disturbed, like either synaptic remodeling or axonal sprouting or neurit extension or synaptogenesis or birth of new neurons. If there is a deficiency, automatically endocrinal dysfunction will come. If there is an endocrinal dysfunction will come, automatically the patient will get the mood disorder. So regarding stress, I said that stress, cortisol secretion, mainly cortisol secretion in response to stress, and normal secretion of and abnormal secretion of cortisol, I'll explain in the following slides. So cortisol secretion in response to stress will produce intraneuronal signaling in the presynaptic neuron, leading to release of monoamine neurotransmitter in the synaptic level. I said that what is monoamine neurotransmitters is because monoamine neurotransmitter is very important for the intraneuronal signaling, like serotonin, norepinephrine, dopamine, histamine. These are the monoamine neurotransmitter. So it facilitates the neuronal plasticity. I already told that what is the functions of, what is the regulations of neuronal plasticity. For facilitating that work, monoamine neurotransmitter, it's very helpful for that. So in depression patient, what is the monoamine neurotransmitter will be reduced, like serotonin reduced, norepinephrine reduced, and like dopamine reduced. If it reduced, it could not able to facilitate the neuronal plasticity. It could not able to facilitate the neuronal plasticity. Automatically mood disorder will occur. In chronic stress, if it is acute or periodical, it's okay. If the stress is persistent, we are not taking as a positive stress, it's taking as a negative, and constant sources it's present, or genetic vulnerability, or episodic mood disorder, or chronic administration of glucocorticoid, automatically impairment of the neuronal plasticity. So neuronal atrophy and death of neuron. I told that how neuron is affected due to increased glucocorticoid. So this is the reason: increased glucocorticoid, increased energy, glucose energy, reduce the protein level, leads to neuronal damage. So neuronal damage occur. This is the normal. What is, I said that in previous second or third slide, I think so. How the volume is reduced, brain volume is reduced, how the increased metabolic activities happen, what is the role between the endocrine and the neuronal part. Just we should understand. This is a basic understand. Normally, what happens when the stress occurs for anyone, automatically hypothalamo-pituitary adrenal axis activation, followed by cortisol secretion, and followed by the neuron, monoamine neurotransmitters, synaptic. It's released from the presynaptic and transmitted to the postsynaptic. There is formation of new synapses, cell differentiation, neuronal resilience, and removal of unnecessary synapse. So what will happen? Then it will be stored as a memory. So whenever the second episode of stress will come, it's try to cope up the situation. So that is, if they are cope upping the situation, it's called the adaptations to stress. We can able to cope up the demand, or we can able to adjust with the situation. If it is not occur, it's not happen, what will going to happen? Just going to the pathological process. It's a recurrent stress. If the recurrent stress are like bipolar affective disorder or obstetric complication or previous episode of depressive, whatever it may be, automatically increased hypothalamo-pituitary adrenal axis activation leads to increased cortisol secretion. I told that what is the reasons of neuronal damage in my previous slide. So neuronal damage occur and leads to neuronal damage. There is no neural resilience or formation of new synapses or could not able to differentiate the cell. So losses will happen. So automatically it disturbing the neuronal plasticity. When the neuronal plasticity be reduced, what are the functions doing by the neuroplasticity is totally damaged, like neuronal loss and atrophy. Automatically what will happen? Reduced brain volume. From the beginning slide, I said that due to reduced brain volume of some of hemisphere, some of part of the brain, and increased metabolic activity of some part of the brain leads to bipolar disorder. You just look into that, how the volume is reduced, how the activation reduced. I told that brain volume, and I told that regarding glucocorticoid, increased energy. So there is a energy level I conveyed, and as well as brain volume I conveyed. I think so. I made you to understand that how the volume is reduced, how the increased metabolism is occurred. This is the pathology behind the mood disorder. These are the things mainly proved by some research article also. Then now we'll go to the theoretical part. So far I explained what is the reason for the bipolar disorder, how it's occur, where is the location is deficiency, what are the biomarker issues present, what is the gene is involved. This is the behind reason. And apart from that, what are the obstacles to recovery? Whenever we are prescribing homeopathy, we should consider what the patient is taking, how long is past history, family history, and regarding the treatment history, very, very important in the bipolar affective disorder. Then only we can give the appropriate result to them. Then come to the classification of mood disorder. Mood disorder fall into the category like represent in the depressive disorder and bipolar related disorders in the DSM-5. Like under the depressive disorder, disruptive mood degradation disorder, major depressive disorder, dysthymia, premenstrual dysphoric disorder. If you are taking bipolar 1 disorder and bipolar 2 disorder and cyclothymic disorder. Coming to the ICD. And the mood disorder, it's fall into the category between the F30 to F39 in ICD-10. And only one thing I want to explain here, whenever we are diagnosing if the first episode of manic is occurred, we can, with the help of ICD-10, we can diagnose the case manic episode. Because in bipolar disorder, previous DSM, it comes under the bipolar 1 disorder. But if the patient, there is no episode of major depressive disorder, there is no precipitating factor, it's currently, we are not getting any relevant point, but at present patient having the elevated mood or elated or irritable mood, you want to diagnose the case F30 manic episode. That is the difference between the DSM-5 and ICD-10. And come to the bipolar affective disorder. Bipolar affective disorder falling into the March 30 World Bipolar Day. And bipolar, its name itself, it's explained that manic as well as depressive symptoms. Normal mood, it's followed by the patient towards hypomania, then go to the severe manic. Or the patient go to the mild to moderate depression or go to the severe depression. This is the bipolar, either manic or depression or both, like both mixed type, manic and depressive types. And regarding Akiskal's schema of bipolar subtypes, and Akiskal's is a psychiatrist who is known for his research on temperament and bipolar disorder. He proposed schema of bipolar subtypes, and apart from that, by DSM and ICD-10, even certain different criteria like bipolar 1 disorder, full-blown mania, bipolar 1A, depression with protracted hypomania, bipolar 2 disorder, depression with a hypomanic episode, bipolar 2A, cyclothymic disorder, bipolar 3 disorder, hypomania due to antidepressant drug, bipolar 3A, hypomania or depression associated with substance abuse, bipolar 4 disorder, depression associated with the hyperthymic temperament, and bipolar 5 recurrent depression that are admixed with dysphoric hypomania, and final and mixed mood depression, mixed features progressing the dementia-like syndrome. Look into the graphical pictures like bipolar 1 disorder, bipolar 2 disorder, and unipolar major depression. It's a center, considered as a normal mood. The blue line, it represents bipolar 1 disorder. What will happen? The patient will go to the manic state for a particular period. Again, the patient come back to the normal mood and again go to the major depressive disorder. Again, go back to the normal mood. It represents the bipolar 1 disorder. So, patient either manic or major depressive disorder. Then come to the red line. If you are considering if the red line, it's represent hypomanic. From the normal mood, it elevates to the hypomanic for a short period, again fall into the major depressive disorder. It will persist for a long duration. Again, it's going back to the normal mood. So, hypomania with major depressive disorder will fall into the category of bipolar 2. Look into the yellow line. Yellow line, from the normal mood, it's come to the mild or minor depression or moderate depression. Then again go back to the normal mood and again fall into the category of major depression. Only here depressive episodes are present. It's called as unipolar major depression according to the DSM-5. Come to the recycling, because rapid cycler, whenever this is a very terms we are using, when we should use the term rapid cycler, per year or within the 1 year or 12 months, they need 4 mood episodes, either manic or cyclothymic or chronic depression or whatever it may be, comes under the bipolar disorder. And how we can consider as an episode? An episode should be complete and the second episode occur after or at least 2 months gap. If the both things correlate, then only we can call it the rapid cycler. Understand when it be called rapid cycler? The 4 minimum episode it's needed, and each after a complete episode, it should be complete. Even after, for example, if I'm getting manic, after your 10 days, patient came to the normal mood. Again, after 1 month, again it's occurring. It's not a single episode. It should be completed after a 2 months gap. Again, the second episode occur. Then only we consider as a single episode. Likewise, 4 episodes should be happen in a year. Then come to the theoretical part. Mania, euphoria, expansive, irritable. It's present in the manic patient. Most of the with increased energy. So all these symptoms should be present 1 week. Then only we can diagnose this case of mania. And regarding the elevated mood about the mania. So what is the euphoria, elation, exaltation or ecstasy? These are the pathological happiness of the mania. And euphoria and ecstasy consider as a normal health mood also. Why? Because euphoria, it never disturbed anyone, and even during that period, euphoric pathological happiness time, the patient psychologically well-being and happiness present, increased productivity and creativity is present. So there is no harm for other, there is no irritability is present. So can consider also. And regarding ecstasy, ecstasy, I said that ecstasy is the final stage of suprasmania, but we can consider as a normal mood also. Why? Because yogi, sage, they says that we are in the blissful level, because when they are reaching the blissful level, those who are under meditation, like yogi, sage, they used to say that I'm in the ecstasy stage. So it is called, so it also considered as a normal healthy mood also. And like again I'm starting euphoric mood. Then second stage is elation. Elation is a moderately elevated mood. So what is the difference between the previous and here? It's a strong level of confidence level and more enjoyment, increased psychomotor activities. It's mainly present in the stage 2 mania. And stage 3 mania, severe mania. So whatever the symptoms present in the elation, along with that delusion of grandiosity is present in the exaltation stage. So it's a third stage. And come to the fourth stage of mania. Already I told that this comes under the normal health people also, normal mood people also. And how to differentiate? Elation followed by exaltation. Patient is very increased activity or hyperactivity with the delusion grandiosity, and suddenly within a short period patient go back to the, there is no increased psychomotor activities, and there is not actively related to the environment. They never participate, never respond to the environment. The two sign will be present. So automatically what will happen? Because it is called as stupor. You know, stupor, it is the one of the symptoms of catatonia. Catatonia having the 12 symptoms. Stupor is the one of the symptoms of catatonia, and catatonia can occur in schizophrenia, mania, autism also. And because it is a wide variety means even the stupor can occur in the medical issues also. For example, cerebrovascular accident, encephalopathy, encephalitis, and diabetic ketoacidosis and head trauma. During this condition also stupor can occur. But in manic phase, how we can diagnose the case? The patient used to convey that, sir, last week full of his irritable, hurting, laughing, delusion, grandiosity. He says that I am the God. I'm coming for the saving the world, save the world, or come to the scavenger. Likewise, they used to convey, and followed after a short period, there is no reaction and refusal of appetite, refusal of thirst, and neglected bowel and bladder movement also. And apart from that, and catatonic symptoms, they never used to blink the eyelids. So when these are the symptoms are present, it's go to the emergency stage because of due to dehydration. When the dehydration, we should admit in the IPD. When the patient during recovery phase, if you are asking the patient what happened to you, only during slight mild recovery phase, if you are asking the patient, chances are there to tell he's feel blissful and equivalent to the God. What yogi, sage, they are express after meditation, the same feeling the manic patient also used to express. That's why it's called as stuporous mania. Then hypomania, increase in productivity and creativity. That's called as hypermania. It's mostly benefit, not necessary to admit the patient. Only it's a feeling of happiness. And I said that regarding bipolar 1 and bipolar 2, hypomania and mania, two categories present. And come to the mental status examination. When come to the mental status examination, what is the general appearance of the patient? How we can diagnose the patient as mania? You know, by the general appearance, hyperactivity, increased amount of energy, they never get tired, and the makeup inappropriate to their age. They are over makeup and like wearing inappropriate, lot of makeup. So like belladonna, lacasis, aurum metallicum, platina, those patients used to give like due to attraction they used to wear a lot of makeup, jewels. It come to the mood and affect, and in previous slide I explained about the what is the different type of pathological happiness. So the same thing comes under the mood and affect. And congruent, I already explained in the previous slide, thought and actions of the patient should be remain. I'll give you some example. Patient believe that he is chosen by God, because at third stage grandiosity present is the thought of the patient. He is chosen by God to correct the world. So how he react, the emotion, the people are against him, suspicious expression or affect should be present. Then it should be a congruent. If there is no relation, it's a incongruent. Come to the speech when you come to the speech, how the speech will be rapid and difficult to interrupt the patient. And we can think of hyoscyamus, lachesis, mercurius, belladonna. And patient become full of, they express by the jokes, rhymes, and play on other words. Our speech may become incomprehensible. We could not able to comprehensible because again, what I said in the speech, most of the drug like hyoscyamus, lachesis, mercurius, belladonna, china, stramonium, it most probably will cover. And come to the thought. What is the content of thought? What is the process of thought? The content, the third stage of mania, I said that there is a grandiosity, maybe type of grandiosity in persecutory delusion may be present. This is a content of thought for the mania for the diagnostic purpose. And if you come to the process of manic patient, thought process in manic patient, thinking is rapid and they are having the flight of ideas, like jump from one thought to another thought. Flight of ideas is the characteristic features of mania. We can say that iridium metallicum, simsibuga, and lachesis. These are the drugs immediately jumping from the topic to topic. And clang association between the thought are related by similarity in sound, but not in the meaning. The clang association, I'll explain the next slide. Flight of ideas, I say is that, and jumping the topic from one topic to another topic very quickly, I say is that distracting cues. And they are having flight of ideas, they are jumping from the topic to topic because of mainly if any slight distraction will come, they will, for example, if the manic patient conveying the symptoms is somebody nearby, they are speaking about money or bell sound or something. He's correlated his thought towards the bell, or he bring the bell sound into his thought, he bring out the other theme. So that's why jumping of thoughts and distraction mainly, their attention, concentration, very poor in the manic patient. So these verbal distraction are of this kind, namely clang association, puns and rhymes. I don't know, I have a video clip. I'll try to play the video clip. If you are able to look into that, I can, this is a one actor video clip. I'm not criticizing the actor also. And first of all, he's a very healthy mental state, but what is the mannerism he's expressing, I can correlate with the clang association, puns and rhymes also. I don't know it's going to run. I'll try once. If it is you can see, I can explain.
Can you hear me, doctor? Maybe
Yeah, I'm
share your entire screen and then you can go ahead for that particular video.
okay.
Share your entire screen and you have to tick that box below.
Yeah, just a minute. I'll do it, doctor.
You can try in that.
Yeah. Yeah, I done it. Can you able to look into that?
No, we not yet started.
No. Actually, can you see the some like screen different? Any different?
You have to stop this one and then you have to again new share it. Yeah. It's open right now.
Now it's open.
Yeah, it's open, but audio not yet started.
No, shall I play? Shall I play?
Yeah. Please go ahead.
Yeah, right. Just a minute. If it is not could not able to hear, just intimate me.
Yeah, yeah.
ஆடாய மச்சி வாழைக்க பச்சி உடம்ப பிச்சி பொட்டுடுதம் பச்சி ஆடாய மச்சி வாழைக்க பச்சி உடம்ப பிச்சி.
Hello.
Yeah, we can hear, doctor. Please go ahead. Yeah.
Yeah, thank you so much.
It's over.
Yeah, right.
Yeah.
I think most of them can able to most of
hear
them are seen this. Yeah, I can able to hear. It's okay, na?
Yeah, okay.
Okay, so the actor, how they express it during the action moment. See, he's saying that he's directly can say that I can beat you. Instead of he says that I will take the unripe banana, I will just peel the skin, I put it over the boiled oils. So he's in his thoughts into the, that is like puns, indirectly connecting. So what is the clang association? See, vadaya machi, machi, bachi, the words what he's saying, the first pronunciation of the word, the second sentence pronunciation of the words are sounds are similar. Like first, that is called as clang association. Third, see, when he's saying that is rhythmically, his body movement and gestures are totally is like rhythmical movement. So this is the clang association, puns and rhymes. These are the very important for diagnostic of many cases. And regarding perception, like hallucination may occur in manic patient in severe stage. Mainly hallucination, I already told her, persecutory. So they can convey through religious or sexual type, like light coming down from the sky, and I can able to hear the God what telling to him. Likewise, he can perception. And regarding cognition and memory, usually cognition are oriented, memory usually intact. And insight and judgment, and insight and judgments are impaired. And come to the impulse control, impulsive behavior in common in mania. Already I told that in serotonin, due to increased serotonin action. And reliability, information from the manic patient we could not reliable, because they tend to lie or try to deceive the interviewer. And reliable, whenever you are collecting the data, reliable data should be taken from the family, relatives and other source. And now we'll go to the unipolar depression. Unipolar depression person experience only episode of depression. There is no manic phase, and include either major depressive or minor depression or dysthymic. It's a dysthymic. If the symptoms of depression persistent more than 2 years, we can diagnose as the case of dysthymic. Major depressive disorder. Whenever you are major depressive disorder diagnosing, we can symptoms of emotion present, symptoms of thought present, and symptoms of physical symptoms as well as the behavioral symptoms should be considered. And minimum 5 symptoms should be persist for the period of 2 weeks. And for the mania, I said that the symptoms should be persist for a week. That is the difference. What are the symptoms? Like 5 symptoms minimum for the 2 week period: depressive mood, diminished interest in pleasurable activities, weight loss or increased weight or increased appetite or loss of appetite, insomnia or hypersomnia nearly every day. What are the symptoms I'm saying? Nearly every day. And increased psychomotor activities and reduced psychomotor activities, because agitative depressive disorder having the increased psychomotor activities, and major depressive disorder is a reduced psychomotor activities. Fatigue or loss of energy, feeling of worthlessness or excessive or inappropriate guilt. It's a very, very important point, because most of the patient, whenever saying there is it's a triflus matter, but inappropriate guilt is helped to diagnose it, and it is one of the very valuable fund for the depression. And normal person can go to the hypomania, then it's going to the manic. And if you are coming to the cyclothymia, or it's going to the unipolar depression and followed by the bipolar depression. Risk factor for BPD patient, two type of risk factors present. One is lifetime. It occurs at any time due to genetic or due to personality changes. And risk factor for the onset of episode mainly associated due to some specific incident or specific situation, like life events, postpartum period, seasonal pattern, or disruption of normal biological rhythm. And come to the comorbid. What are the disease associated among with the mood disorder? Anxiety disorder, phobia, panic disorder, OCD, alcohol and drug dependence, conduct disorder, and antisocial behavior. The conduct disorder and antisocial behavior mostly present with the manic episode. And differential diagnosis, organic causes of like organic mood disorder, dementia, acute and transient psychotic disorder, non-organic psychosis like delusional disorder, adjustment disorder with depressive mood, general anxiety disorder, normal grief reaction, OCD. What are all the scale? Why we need scale? Because we need a rating scale for monitoring the patient for a period of time, and we can provide more comprehensive information about the patient by physical activity, cognitive level, and vegetative functions. The three things important to describe about the mood disorder. So all the things will be present in the mood disorder, and apart from that, before and after treatment, how the patient improved. It very helpful for the clinical research studies. What are the scale we can use it? For bipolar disorder, about the serious or intensity about the disease, we can use clinical global impression for bipolar disorder, modified version. In only for bipolar disorder, mood disorder questionnaires, bipolar spectrum diagnostic scale, and Barcelona bipolar eating disorder scale. Come to the only depressive phase in bipolar disorder. Beck depression inventory, Montgomery and Asberg depression rating scale, Columbia classification algorithm of suicidal assessment scale. Come to the manic. I finished bipolar and depression in the bipolar. Now mania in bipolar. And Young mania rating scale, clinician administered rating scale for mania, and for hypomania checklist, HCL 32. Coming to the pediatrics group, child behavior checklist and Young mania rating scale for parents version, children global assessment scale. Mood and temperament. How we can think of prescription during clinical prescription when we are treating the manic patient or depressive patient or mixed type. Psychological, what is the, how I expressed my character, how, in which condition my personality will be predisposition, how my mannerism, how my thought, how my action. From the beginning I'm saying that thought and action, and it express the mannerism and my personality as well as my own character. It be decided by the psychological and the biological organization. The two things will be organizing this follow of the category. It represents as a temperament. So in order to deal, and each and every patient having that unique nature, you know, we are prescribing the natromur for the manic also, we can prescribe the natromur for the depression also, we can prescribe the natromur for hypomanic patient also. But when they are, each and every drug, they are having the bipolar action. So medonym is very cruel, as well as the medonym is very soft, kind, very anxiety about conscientious, very conscientious person as triplus. So each and every drug having their bipolar activity. So how we can decide it? Because each and every patient have their unique natures. So how they are expressing, what they are expressing, how they are affect, and how they are emotion. We should differentiate from the other patient, then only we can prescribe the similar drug. And Eysenck, in his book of personality, individual different have classified the temperament as given below. It's a normal person. Patient may be emotionally stable or emotionally unstable. So personality fall into the category of sanguine temperament. There is that, and melancholic introvert nature is that. So, what is how I can correlate with mood disorder? Each and every temperament has its own strength and weakness. It's common, quite common everywhere. Each and every person have their own capability and own weakness. And Dr. J.H. Allen also quoted the same. We study temperament closely. We see that peculiar temperament predisposed to diseases. The temperament is given the strength as well as the weakness. When emotionally the person, I told that their mannerism, action, thought, it's due to emotionally disturbed, it going to predispose to certain type of diseases. And it's called as outwardly reflected picture of the disease. I'm given, as per my understanding, I given certain example. The sanguine temperament can or may fall into the category of or they predisposed to or getting the euphoric mania, and choleric temperament fall into or getting chances are irritable mania. Melancholic patient getting depression and insomnia. Phlegmatic personality chances are there to get cyclothymia and hypersomnia. And human being are 1,000 times more complex than the in the most and certainly we should accept, because whenever the patient coming, they are prescribing for the calm personality, although will prescribe the hyperactive persons also will prescribe more. What is the differentiation? We should define why the hyponess and hyperness occur. What is the temperament is predisposed? Where is the weakness? Where is his strength? If you are understanding while the prescription, really will be giving the similar prescription, the patient used to get the speedy recovery. And before going to show the slide, I'm taken few rubrics, which is cover mania, hypomania, depression, and mixed type. But only a single rubric. Based on this rubric, we could not able to prescribe. However, it may be the characteristic features of the patient. We think of those remedy. That is my ultimate aim. I'm not prescribing if the patient is having this rubric, you prescribe this. Not at all. You seeing as a whole and seeing as a what is a predisposing factor, precipitating factor, and premorbidity should be confirmed with that. And for example, and sulky, we can take in, is common in the pediatrics ward, sulky nature. Sulky most commonly is a feature of depression and personality disorder. Sulky, antimonium crudum, merc, maxomica, calicar, alumina, maca. And sulky, it's a withdrawn nature. Aloof, and another rubric we can take of aloof, reserved. The facial expression is very important for the pediatric. See, the face from it happened in. I'm not satisfied with anyone. I'm very sad. Whatever you are conveying, I'm not conveying. And so by the wrinkled face, mostly it occurs in the depression. And most common remedies are chamomilla, naxomica, lycopodium, veratrum, album, sepia, and stramonium. Common to the argumentative mainly in hypomania and mania. When the cruelty is more, go to the or hurting tendencies there, go to the manic, or think of the only argumentative, talkative, protectivity. Think of hypomanic. Mainly is naxomica, sulfur, and or metallicum, argumentative. Pessimistic, and you know that I'm not going to explain much regarding nitric acid, naxomica, soranum. I'm here mentioning one or two drugs only. Lot of drugs are there. And lability, sudden change of mood, and Staphysaccarea, pulsatilla, ignatia, lycopodium, and labile mood, sudden change of mood, laughing, alternate with weeping. Like mostly in hysteric patient, deliric patient, and like manic towards hypomania to mania. This condition, most of the symptoms will be suitable, like laughing, alternate with weeping. And manic also, mercurius, pulsatilla, moschus, nax muscota, stramonium, and hyoscyamus. Come to the hilarity, boisterous merriment, exhilaration. I told that one of the third stage of manic symptoms. So think of cannabis indica, Hyoscyamus, Coffea cruda, Lachesis, Natrum carbonicum, and most of the natrum group very mild compact, but the natrum group, natrum carb is a very vicious. It's a very cruelty patients. Even it's a one in the natrum group. Like in Macar, Magmure is a very characteristic features. Likewise, a very characteristic features in the clarity. Opium, Crocus sativus, and Phopis, elegant, want to be elegant, want to be dandy, and always preoccupied with this cloth, lipstick, and the beautiful items like jewels, whatever it may be. So think of Platina, Baratrum, Naxomica, Phosphorus. Alacrity. See, when you are saying alacrity, it mainly present mania and hypomania. I'm ready to do anything very immediately. That is called a see. When the clap is there, they are quickly or eagerly seeking the clap. If the clap is started, they started to act. Likewise, patient, when we are talking to the patient, he is very closely observing us. When the doctor is going to finish the talk, suddenly, abruptly, he is giving the answers. So, by physically as well as mentally. So, it's you can take it as a alacrity, and you can take it as a sub-rubric like overactive, agility, and playfulness. Aura metallicum, Canopus indica, and Canopus sativa, China, Coffea cruda, Sepia, Veratrum, Belladonna, Hyos, Lachesis. Talkative, I'm not going to much emphasize, you know everybody. And Lachesis, Hyoscyamus, Stramonium, Argentum metallicum, Argentum nitricum, Phosphorus. See, you know, talkative is that what is the nature of talkative? How they react, how they explain, what the content of that should be understood. Then only we can prescribe the remedy. You know, all the talkative patient must not fall into the category of Lachesis. All the talkative patients, see, when I told one, I showed one example of like a video clip, it's resemble like Hyoscyamus. The Lachesis never, because Lachesis is a very clever patient. What to talk, when to talk, how to talk. He only know. He never expressed anything very like without belief. He needs some confidence. Then only he reveal the things. That's why Lachesis is talkative. And Argentum metallicum, very less patient we can see. And Stramonium, do when mainly in ADHD and mainly seen in the manic, severe manic condition, we can see in the Stramonium. And Argentum nitricum because of due to anxiety, because many Cali groups, MAC groups, and most of the things, even though covered, it's having the psychotic tendency to explain because he want to reach the things. That's why the talkative present the Argentum nitricum. Phosphorus, you know that. And hyper-spirited personality, hypomania and mania. You are under my power. So he know that it's a more confident. I'm in the second stage of mania. It's a second stage of mania, exaltation. Hyper-spirited, Hyoscyamus, opium, Veratrum, verbascum. And debauchery, seeking sensual pleasure, mainly present in the manic patient. And hypomania very less. Fluoric acid, citric acid, sepia, medorinum, naxomica, and phosphorus. And Hahnemann integrates temperaments and humors into the classical materia medica because it helps us to understand who we are treating, as well as what the form of the patient, what the nature of the patient should understand. And this is true to such an extent that the state of patience and mind and temperament is often most of the decisive important in homeopathic selection of temperament. Everybody know about this temperament. Certain drugs fall into the certain temperament. And more thing I want to convey that a person is not necessary to fall into a single temperament. Maybe he can have combined temperament or two temperament or three, like sanguine, nervous, choleric, melancholic, phlegmatic. And given some drugs, you can consider this drug also. And before going to finish, I would like to say that whenever you are before going to prescribe the remedy, please keep in your mind aphorism 230 in footnote say you never give the agonate to the calm person. Naxomica which never work in the very soft kind person. It mainly serviceable in irritable disposition. Pulsatilla work mostly in the mild and yielding disposition, and Ignatia does not work in those who are easily frightened and vexed. So each and drug nature and patient's nature. You should consider the both. If the similarity is present, you prescribe the similimum, it will exactly act and speedy recovery will get. These are the papers and these are the journals, these are the books I refer for these chapters. And thank you for all for patient listening. Your suggestion regarding this presentation is highly appreciated for me. Thank you.
Yeah, thank you. Thank you very much, Dr. Moorthi, for your extensive work on mood disorder. Let me appreciate for your in-depth, I think in-depthly you have worked a lot on mood disorder, which you were able to see with this presentation. Thank you very much for sharing with all of us. And now let me request my colleague, Dr. Dastagiri, to deliver vote of thanks on behalf of NHRIMH from Assistant Professor from Department of the Medicine. I request Dr. Dastagiri, please over to you.
Okay. I'm audible to everybody? Yeah, I'm Dr. Dastagiri.
It's audible.
Yes, thank you, sir. I'm Dr. Dastagiri, Assistant Professor, Department of Practice of Medicine. It's my privilege to give the vote of thanks to this beautiful webinar on mood disorders. First of all, I express the gratitude to our officer in charge, Dr. K.C. Mulidan sir, for his innovative mind behind to conduct this type of webinars on this crucial period without losing the thrust towards to disseminate the knowledge to the homeopaths. And after that, I will like to extend to special thanks to our beloved principal, Dr. R. Siddharthan, for constant motivation to learn new things and providing encouragement and support from all of side. And also, and finally, extend to my sincere thanks to our HOD, Department of Psychiatry, Dr. N.D. Mohan sir, who will share his knowledge and experience in the Psychiatry Department. And the focus of the limelight of this person today, Dr. S. Karunakara Moorthi, Assistant Professor, Department of Psychiatry, who delivered the beautiful lecture on mood disorder in extensively, both philosophical point of view, medical point of view, and the psychiatric point of view. I want to share some silent feature of this webinar. He covered the normal phenomena of the stress and pathological stress in very beautifully in relation to mood disorders. At the same time, categorization of the elevation mood, like 4 stages he explained: euphoria, elation, exaltation, ecstasy. It is also useful for not only diagnosis of mood disorder and also to selection the rubrics and selection of the medicine also it is very useful. And the on mood and temperament, what you call it, the disease diagnosis and philosophy is a very amazing, sir. I expect the same type of presentation in future also. And I'm very grateful to Dr. Dana Prakasham for briefing the introduction and Dr. Jayashree to organize this event successfully without any interruption. And finally, as no program can become successful with a single person, so finally I have to thankful to all our participants, faculty members. Without your participation, the webinar will not succeed. Thank you for making this event successful with your contribution. And I ensure you in the future will be conduct this type of innovative, informative, enlightened webinar that will help you both in academic and research wise. Thank you one and all.
Thank you, Dr. Dastagiri. Thanks a lot for your vote of thanks. Dr. Moorthi, can we go ahead for a few questions? I think
right.
3 questions are there. First question, TSH increased, increase in TSH. This is the primary diagnosis because depression is a part of symptom complex of hypothyroidism. So if thyroid is increased, so can we tell it as depression? Can we have to take it into the diagnosis mainly as a depression? In that way, one participant is asking, can you able to?
Okay. Yeah, I'll tell that.
And what about the diagnostic point?
Yeah, right. I'll say that. When
I hear you. Yeah. If thyroid is elevated, what we...
Sorry, lost your voice, sir.
I request all the participants to...
Hello?
Yes,
Hello,
now
Dr. Jayashree, is it audible for you?
Yeah. It's audible.
Okay.
They're asking
Can I?
what, if thyroid is elevated, what could be the primary diagnosis?
Doctor, actually, either you want to relate it with mood disorder, means when you are taking the detailed case history, when you are taking the detailed case history itself, we understand. And already I told that it is a bi-directional relationship. So you should understand how it's happened, either the puberty, what is the age group, and how it started, and how it's react. And I'm given the for
no, so,
mood dis. Yeah.
so my question was, if there is increased TSH in a patient with depression, is the
Okay.
diagnosis depression or is the diagnosis hypothyroidism?
Maybe if both things will be present, depression with hypothyroidism. But that's why I want to explain that if the patient, which is the first, how it started the symptoms. After mood disorder, the patient developed to the thyroid dysfunction, or after thyroid dysfunction, patient get into the mood disorder. It's a bi-directional relationship. I told that even whatever it may be, glucocorticoid or thyroid, whatever it may be, it's a bi-directional relationship. We can't say that it's a purely depression. It's one of the thyroid is one of the causes for the depression.
Okay, thank you, sir.
Okay, thank you.
I request a participant to unmute. We will be discussing whatever questions in the chat box. And one more question, Doctor. This is not related with the presentation, but so many students I could able to see participating quite a lot. So it is from one of the student side. What are the options to practice psychiatry after BHMS?
Means what they are expecting. Can you explain a little bit?
So maybe immediately after the BHMS, how can they practice psychiatry in that way? I think this maybe from the intern side.
Okay. I'm honestly saying that I'm not from the MD psychiatric. I'm pure MD Materia Medica. And so whatever it may be, psychiatric, cancer, whatever it may be, our approach is the same. There is no much different. Even they are following Alansky notes, or even they are following Flip and Bailey, or even they are following certain other books also. There is not much necessary. What is your important role? How depth you are understanding the patient. Whatever patient, not necessary to afraid. Even first you understand the theory as well as the pathology of the disease and the at present emotion level of the patient. This is what I am doing. Even for cancer also, even for the gallbladder stone also, even for the psychiatric also, we know that's why I took this mood disorder, because the depth of mood disorder you understand, then we can prescribe the medicine. So no need to confuse that. Even though if you are not seeing the psychiatric patient, at present emotion level, you can prescribe what you know. Hello, Dr. Jayashree, if they are satisfied, okay, or else what they are expecting, I can give answer appropriately.
Yeah. See, at least after finishing the VHMS, if any psychiatry patients are coming up to our clinic, that we should not say that this is not our area. So at least we could able to diagnose the cases, and so that we could able to treat well with our sector also. And as we know that in allopathy, a set of medication, the psychotropic medication, what we are having right now, contains a lot of side effects and all. And mainly in Kerala, I have seen the approach of the patients. They are coming more towards the homeopathy, especially in Kerala. I could say able to say they are having more knowledge about the medications as well. So the role of homeopaths increases to create awareness about the psychiatric disorders. So one should be thorough with these disorders in order to diagnose these cases at least. And we could also able to treat the same way as allopathic people are treating. Okay, even so many here in our institute, we could able to manage the acute set of symptoms also. Right now, we are not running the IPD, but still we could able to manage very well even the acute symptoms also. Only with the homeopathy also we are seeing that. So one should not miss the diagnostic point of view. So in that way, today's webinar we have kept. In the future also, we will be conducting so many webinars, mainly in the psychiatric aspect. So it's a big area, I can say. So every monthly we'll be taking this, hopefully. Yeah. And yeah, there are a lot of questions, but still due to the maybe we will share the email ID. One can email us their questions. Okay. And one more question, I think, how neuroplasticity is related with depression.
Doctor, in my slide, I said that whatever it may be, it's a depression or mania. This is the functions of the neuroplasticity is having the, I mentioned in 4 functions. There is a resilience functions and as well as new growth and as well as new formation of neuronal. These are the function will be reduced automatically. It will related to the endocrinal dysfunctions. For example, I will say if the neuroplasticity changes is that automatically thyroid dysfunction will occur. So thyroid dysfunction will occur automatically leads to the patient used to get the anhedonia, anergia, amotivation, these kind of symptoms the patient used to get. So it automatically depressive symptoms.
Hello.
Hello.
Can I speak?
Yeah, sir.
Thank you. Thank you, Dr. Karunakara Moorthi, for your wonderful presentation on mood disorders. I'm Dr. Thomas M.V.
Okay,
so it's a wonderful session. I think you have well explained on the neurobiochemistry of depression, and it was a very nice session. And I have raised some questions regarding to your presentation. So you haven't mentioned anything on behavioristic theories and psychodynamic theories. And also, my question is, another question is, I think is child behavior checklist can be used for the diagnosis of depression. I think it's not for finding out the depression in children. So could you please give me some explanation on that? And also, and you had said something on hallucination that is related to religion or sex. So actually, what do we mean by that? Hallucination with religion and sex. So I'm eagerly waiting for your answers, please.
Yeah, surely I will explain. And first question, you are raising that perception. Like perception, mostly in manic patient, 2 kind of perception. Like hallucination, whatever it may be, delusion, say grandiosity.
Yeah.
Grandiosity, they used to say that I am the God, or I am sent to the world by the God.
Yeah.
This is their thought. What is the, this is their mood. What is the affect? What is the affect here means how they express. See, all people are enemy, so they are seeking me, they want to kill me. This is their action. So grandiosity, their thought and action is correlated. So grandiosity delusion and persecutory delusion, it's quite common. And the way of expression, either by religious or by the sex. That's why I took the Rubik Depatchery. These are the medicine.
So
this is most commonly seen in the manic patient. It's not 100%, only the grandiosity and persecutory present. Maybe other delusion also can occur. I'm given some diagnostic point of delusions.
Okay, sir, in case of hallucination or in case of delusions are false beliefs and hallucinations are false perception. Yeah, right. In hallucination there are 5 kinds, right? Is visual, auditory, tactile, and gustatory. And
senses, also, wherever the senses perceptions of all, you can consider.
So I cannot understand, correlate with this religious hallucination and stuff. That's why I raised the question.
Okay, sir. For example, I am saying that one example I have given. For example, visual hallucination. I taken only one part because if I'm explaining the mental status examination, it will take long. Even that I'm not explaining the mental status examination of depression. I know that because already it is 100 slides. If I'm taken, it will go more than that. So mainly, I took visual hallucination. They say that, see, I'm the seeing.
That's answer. Okay, right, sir.
Visual I'm seeing the God. I'm seeing the God, so I can able to see him. She's guiding me, and she's like I can able to hear. This is auditory hallucination. If the patient God is directly talking with him, we can take it as a secondary person auditory hallucination. If the God is telling to someone that he is the person, he came for the controlling the world, he can help the people. It's a third person auditory hallucination.
So these are some auditory and visual hallucinations.
Yes, both it will be present. Because,
okay. Then next
because
one
he
is,
hearing what God says. That's why auditory hallucination.
These are the common symptoms in schizophrenia, right?
Yes, schizophrenia also.
Right. Okay. So
that's why in previous slide I explained schizophrenia and bipolar disorder. Crippling is distinguished by bipolar 1 disorder.
Okay. So, sir, how can we use child behavior checklist for finding out depression in children? Is it true? Is it possible?
Checklists, sir. Actually, whenever we are using the scale, first you look into the chronic alpha. That is mainly authenticated scale. And second point, I would like to say that it's a checklist different, inventory it's difference. Because if you whenever you're using the checklist, whether the symptoms is present or not. But Hamilton depression scale, it is authenticated. Cronbach alpha, if it is more than 7.5, it is an authenticated scale. You can use confirmatory assessment scale.
Sir, why I have raised this question because I have done my PhD thesis on learning disability and behavioral problems of children, because I have used the same checklist in Malayalam CPCL. So there is only 3 scales are there: internalizing symptoms, externalizing symptoms, and social thought problems. So there is no depression items for depression in CBCL. That's why I raised the question. Okay.
Sir,
okay, one more question that I have raised is you have well explained about the neurobiochemistry, but you had not mentioned anything on behaviorism and psychodynamic theories. Am I right, sir?
Yeah, right, sir.
Okay.
Because I already told that it's a 100 slide. If I'm going very depth now, it will take much time. That's why maximum shortcut. Yeah.
It was nice to hear, and all the best, sir.
Yeah. Thank you. Thank you very much.
Thank you, Dr. Thomas. And one participant is asking that there is no mood disorders in DSM-5. Actually, in DSM-5, the chapter itself is not on the name of mood disorder. They divided the chapter as bipolar and related disorders and depressive disorders. So in 2 chapters, they have divided. But if you want to see in ICD 10 from 30 to 39, they have categorized under mood disorders. So both bipolar and depression they have given in ICD 10, where you can't see in DSM 5. DSM separate 2 chapters. Okay, and I think we have answered all the questions. Any further questions? One can unmute themselves and can ask Dr. Moorthi. Yeah. Anyone want to go ahead with further questions? I request the participants. I think we have done with the questions. So many questions we have asked, we have answered. Yeah. So repeatedly they are asking what are the options for practicing psychiatrical illnesses after BHMS. I think we have answered this question.
Sir, and I would like to say only one thing.
And
for bipolar disorder, because when I'm treating the patient, sometimes I could not, even though I'm after understanding, it's give a lot of failure. And some cases simply can give you a wonderful relief. Then I understand that where should I get the exact. When I read the mood disorder, I felt temperament it most suitable for the treating the I taken the option. Maybe it's right or not, I don't know exactly. I taken the options when you are considering the temperament, where the disposition is came, where the weakness we will treat. And that's why I'm given the some of few example. Through that, I will confirm the characteristic features, alacrity, or the way of expression, debauchery. Like it's few rubrics I have seen frequently in the hypomanic manic patients. So basis on that only, I prescribed for the hypomania and manic patient also. Hello.
Yeah. Thank you, Doctor. Thank you, Dr. Moorthi. I thank you, everyone. I thank all the participants for their active participation. And one can visit our one can again see our webinars under the name of NHRIMH webinar in YouTube. We will be uploading soon all our webinars. Already their webinars are there, the previous webinars. Yeah, and I thank you once again, one and all. So here we will be winding up now. Yeah. Okay. We're concluding the session now. Yeah. Thank you. Thank you, Dr. Moorthi, once again.
Yeah, thank you, doctor. Thank you.
Thank you, sir.
Okay, thank you, doctor.